So good morning, everybody. We are going to start this video symposium, which is called When the Going Gets Tough, the Tough Get Going. As you can see, the tough guys and girls are already here. Can I have the intro video of the session, please? Audiovisual. Boris, please. Excuse me. Who is the audiovisual team? Audiovisual team की तरफ. नहीं, कहाँ है audiovisual वाले? चलवाना है. Okay, thank you. So today we are going to present to you some of the toughest guys and girls in Indian ophthalmology, that how they salvage the situation. And I'm extremely thankful to General Boris Meligan, who has come all the way from Moscow. He is our chief judge. To our other judges, Dr. Gaurav Luthra, Dr. Namrata Sharma, Dr. Jagat Ram, Dr. Rohit Om Prakash, Dr. Naren Shetty, if he can come here. Dr. Mohan Rajan, Dr. Rajesh Sinha, Dr. Saurabh Patwardhan. So it's going to be an interactive video session. This is the 35th season, and in this video session, the presenter, they are going to show a challenging case situation, and judges can stop them in between and discuss that how the different thing could have been done in that particular situation. And in the end, we are going to have winner and runner-up toughest guy and winner and runner-up toughest girl. So for this session, this time we had more than 100 submissions from all over India, and these are the top 12 finalists for this session. And we also have 5 consolation prizes whose videos are very good, but because of the time limit, we couldn't add them in this session. And I'd like to mention them, and we'll giving away the prizes after the session along with the final prizes. For consolation prizes, Dr. Saloni Sinha, if she is here. Dr. Jayashri Barua, I can see her. Dr. Ashish Lal, Dr. Neetu Latif, and Dr. Meera Rahim. So we'll start with the first presenter, and it's Dr. Nilesh Kumar. Yeah, please come, Dr. Nilesh. So he's going to present a case, what lies behind. A very interesting case of an intumescent cataract. And audiovisual team, can you have the video of Dr. Nilesh Kumar? Nilesh.
Thank you, sir. Thank you for the opportunity. Can we have the music, please? Little low volume. So I'm going to present a case of matte intumescent cataract that was performed by me and Madhvi Netralia in October of last year. So there are no financial disclosures. So a routine case started with the 2 side ports and one 2.4 main entry from the temporal side. Stained the capsule, did a soft cell technique with Haldipurkar forceps, made a excess, everything going quite well. Was very thankful that the Rexus was complete and circular. Did a hydro. Then I started. Then I started to do the cortical cleanup first, and then I started with direct chop. But I was not able to hold the nucleus, and I am using a blunt forceps, not a sharp chopper. And when I just notice now, I can see a clear glow from the back. And now when I try to hold, you can see there is a large rent, and the nucleus is going to fall off. So it is very intimidating for a surgeon. I was, I think, 4 months into my practice, in my private practice, and this is happening. So what I do, I have a little bit of training in VR, so I just put a pars plana infusion with hope that the nucleus doesn't fall off, and the infusion will keep the nucleus above. So I just do the vitrectomy with the infusion on so that the nucleus doesn't fall. And when I feel that the nucleus is completely free, I stain with triamcinolone just to check that, okay, everything, no vitreous in the AC, and the nucleus is completely free, no tug on the retina. And now I just enlarge the incision, dial the nucleus into the plane. Now, mind you, I am operating on Zeiss Quattro 700, no financial interest in this, but this machine has excellent chamber stability. So even with the large incision, I was not afraid to put the scaffolding first. So I put a 3-piece into the sulcus. You might think that this is blind, but I was able to see through my microscope. So the lens went into the sulcus with optic capture, and then I introduced my phaco probe. You can see so much of leak, even the iris is prolapsing because so much of their thing is there in the nucleus to hold. But still, rock solid chamber stability. I am actually doing this phaco in the pupillary plane, not in the AC. And after that routine, everything goes off within a minute. And then I thought that I won't do a suturing, but I was wrong. The iris kept prolapsing, so I had to put a single suture in this. So that's how the case got completed. Very fortunate, the patient was at the end of 1 week 612 partial uncorrected, and at 1 month with one cylinder he is seeing 6.6. So that was my case. Thank you, everyone.
Thank you very much. So, General Boris, he succumbed to the situation or he rose to the situation? Can you have the mic, please, of General? Yes, it's on. Yes.
I think Dr. Kumar managed this case very well. So it was absolutely
Thank you, sir.
a great idea to use IOL scaffold. Although it might be a better idea to make a suture before you do phaco, because I've seen that there was an iris prolapse and the iris was coming out. Probably the incision was a little bit too wide.
Yes.
During your manipulation. So, however, it looks like it did not cause any damage to any significant damage to the iris tissue. So, and the other comment I would love to say is that when doing IOL scaffold, you don't have to touch the optic of the lens with the vibrating phaco tip, otherwise you get scratches on the optic. So you have to be quite careful, and this is the second take-home message that I would love to deliver. But perfectly done, and nice outcome, and congratulations with this great
Thank you,
case.
sir. Thank you so much.
Dr. Mohan, yeah, quick comment.
I think it's been a very good demonstration how to manage, and you have done a pars plana vitrectomy also. Pars plana approach is very good. Only thing is, did you look at the fellow eye in this patient? What was the fellow eye like?
The fellow eye for the PPC components, sir.
Yes.
Yeah. So the patient was having he was pseudophakic done elsewhere, and he was having no PC rent. So that's why I did the hydro procedure. Otherwise, I don't do hydro procedure in my macular deficient cataract.
Always I say, when you have a mature cataract, always look at the fellow eye. Fellow eye has got a ACI, iris claw lens, a lens in the sulcus. You need to suspect this PPC.
Yes,
and I think you have done it very well. The IOL scaffold also is very good.
Thank you, sir.
Okay, thank you very much, Dr. Nilesh.
Thank you, sir.
Total, how many marks you had to give?
Out of 10, you have
10.
to give. Yes. So next we have presenting for us Dr. Vanashi Nair. Please come on that podium. So we'll be presenting her case of pseudo-exfoliation all in one. Let's see what all she did in one case. Can you have the, yes.
Good morning, everyone. So this was a case of pseudo-exfoliation with a small pupil and weak zonules, a 64-year-old male. And when I looked at the A-scan, the ACD was significantly low in the eye to be operated, which was the left eye. So I had my mind prepared that I could have some difficulties here. So as I began the case and took my incisions, I stained because it is important to have good visualization. As I finished staining, I noticed that the pupil is quite small. In spite of putting dispersive viscoelastic, the pupil is tending to be small. I was expecting some complications ahead, so I thought it is better that I have a good visualization. So I used the 6.25 mm Maligan ring. As I'm inserting the Maligan ring, you can see that the iris, the AC is quite shallow. And it was a little challenging to get all the scrolls. But with the help of two Coughlins hooks, we can engage each scroll comfortably into the iris margin without causing any damage to the capsule below. You need good OVD and a little bit of patience to get all the scrolls engaged. Now here, as I begin the capsular axis, I noticed that I'm not able to take the first nick. However, I'm trying. The whole nucleus is moving side to side, so it gives an idea that the zonular apparatus is quite weak. So I take a deep breath, and here I inject some more viscoelastic to flatten the anterior capsule, and I try again. So here you can notice that I got the first breakthrough, and I'm able to initiate my rhexis. As I raise the flap slowly, I'm going ahead in the anti-clockwise direction. I'm a left-handed surgeon, so you can see that I'm using my dominant hand. But as it was going very slow, I thought that let me switch over to the micro rhexis forceps. That will give me more control. But as I reached this quadrant, I noticed that it was causing undue pressure on the zonule, so I used two micro rhexis forceps to give a little bit of counter traction, so I can proceed with the rhexis on the other side. Some more viscoelastic, and with my right hand I could comfortably again go ahead with the capsular rhexis, and finally managed to have a completion of the rhexis with multiple attempts from using both the hands. So now I went and did hydrodissection, some more viscoelastic, and I began, I knew that the zonular apparatus is weak all around. So I thought, let me give an anterior posterior support to the bag. So I used the capsular hooks, the 4 hooks in all the 4 directions, so that my bag will be stable as I proceed with the phacoemulsification. As I began trenching and debulking the nucleus, I realized that it was a little softish kind of a cataract, and I was not able to get any grasp over the smaller pieces, and it was crumbling. So, and more of manipulation would again, weaken the capsular bag more. So, because the nucleus was a little debulked, it was easier to go and put the capsular tension ring. That would give me more confidence. That would give me more confidence to ensure that the bag remains stable with an equatorial support. Then I proceeded with the phacoemulsification, and as you can see, when I began the cortex aspiration, it was a very sticky cortex. With the CTR in place, it becomes more difficult. So bimanual is a very good technique to go here. With more patience, you can shear off all the cortex, and here you can see I'm struggling with the last bit, but I didn't want the PC to be affected. So slowly and surely, just with a lot of patience, I managed to shear off the last bit of the cortex. Now it was time to get rid of the capsular hooks. And as planned, I had kept a 3-piece IOL standby just in case if there was any other inadvertent situation. So I implanted the 3-piece IOL in the sulcus here, and then it was time to take out the Maligan ring scrolls and take it out of the eye, remove the OVD, and that's the end of the case.
Thank you very much. Dr. Namrata is here, our Chairman Scientific Committee, ma'am. She rose to the situation or succumbed?
No, I think she rose to the situation. and she did very well. And this case really highlights that if you are perseverant, patient, because the temptation is, to just finish it off, but that was not the case, and you used adequate optimal devices, optimal aids, whatever were required, and important messages that you should have all of these ready in your armamentarium, because you never know when you might have to use them. So I think she did a great job.
Okay. Dr. Nareen? Yes. Nareen Shetty?
I think fantastic show of skills, very, very nice surgery. I think a very important point which you brought, sometimes, in these kind of cases, removing the cortex can be a little challenge. A good way to handle in such scenarios is using a viscoelastic or, a dispersive or cohesive, whichever is it, in the bag, and then, do it so that it just holds the posterior capsule more further away, because a lot of times we just keep doing IA without putting visco in the bag, and then it just keep coming up. So a viscoat or even a cohesive also works really well. So fantastic.
Can I make a comment?
Yes, Mohan sir.
I think it's a beautiful demonstration, Vanashi. Is very, very nicely, especially the bimanual rexis with the left hand and the right hand. It was so good. Only thing I would have deferred in you, whatever management, is that nowadays with severe pseudo exfoliation like this, I put the lens in the sulcus, a multi-piece lens in the sulcus, and capture the optic in the bag. This is a technique which I learned from David Chang, because if you notice, if you leave it in the bag, the pseudophacodinosis will be there. And most of these patients, after a few years, 5 years, 6 years or something like that, the entire lens bag with the CTR will dislocate into the vitreous cavity. Boris, you have anything different from that?
I agree that you borrowed my comment, because I think it's a good technology. Although it's not the 100% cure, I have a couple of patients to whom I had to refixate these IOLs implanted in the combined manner in the sulcus and with optic capture. So it may work at some point, but we don't have really good evidences whether or not it is superior to the traditional approach. So we need time and studies to do that.
Also, I would like
Yes.
to add, in these kind of scenarios, what will be very nice is a good anterior capsule polish.
Yeah, that's
to
very
the very
important.
end, because a lot of times, this kind of fibrosis contract, and because the zonules are little on a weaker side, they break easily and then just drop. So it's good to be as meticulous as possible before you remove your ring. Good anterior capsule polish, anyway posterior capsule, anyway all of us do. But a good meticulous anterior capsule polish for all pseudophakic patients, I mean pseudo exfoliation or RP patients, it really helps in a long.
I think you have done excellent job, and in this situation, if you find that it is much more subluxation, then in that situation, you can fix the capsular bag with the Sioni ring, one or two eyelid Sioni ring or MS segment. That is one. Another thing is that while implanting IOL, I think one can implant the IOL and then remove the rexis for those hooks. But overall, excellent.
Thank you so much, everybody. Dr. Arup wants to.
Yeah,
Yes.
this is an excellent demonstration of difficult cases. Just I could have different 2 to 3 part. Just say the before capsular hook implanting a capsule, I could have removed the ring, because if you try to put a hook and support the equator, sometimes the ring and any pupillary device, it restrict the movement of the capsular hook. And one thing I could have implant the lens in the sulcus and capture the optic, and some kind of polish in the anticapsule so that it can prevent some kind of fibrosis. Otherwise, it's an excellent demonstration. And if in any pseudo exfoliation or where you can suspect some kind of zonulopathy, maybe then it is better to use a capsular hook or a iris hook to enlarge the pupil rather than the pupillary device, so that you can disengage disengage from the pupil and hook the capsule margin.
Thank you so much. Thank you so much. So these all generals have seen so many of wars. They have fought so much in their OT. That's where their experience is coming from. Thank you so much for contributing to this case. And next we have Dr. Devat Shah from Indore. will be sharing his case on refixing subluxated IOL.
I think Dr. Harshul, the toughest decision she had to make is whether to use Malugian ring in
Ah.
Kolkata
Ah.
instead of BHEX ring, where judge is Dr. Malugian. I think.
Yes. Okay, Dr. Devat.
Can we have the sound, please?
Yes. Can you have the sound from video?
A 62-year-old female with epilepsy got her cataract done at a nearby hospital. Unfortunately, she had an attack of epilepsy and she fell, which led to scleral tear with IOL dislocation in her only seeing eye. They operated the scleral tear, removed the IOL and placed a secondary SFIOL, but unfortunately that SFIOL also got subluxated, hence she was referred to us. On presentation to our OPD, the eye looked scarred from all ends. The superior conjunctiva was scarred due to the scleral tear repair. The 3 and 9 positions were also scarred because of the old SFIOL pockets. Hence, we were in an ocean of troubles with a near total aniridia, a subluxated 3-piece, poorly taken scleral sutures and scarring all around. And of course, this subluxated SFIOL. So what do we do now? How do we fix this situation? So the brain said, let's refix the same IOL in the area which is devoid of a scar. So the surgery began with a 2-port vitrectomy system. That is, one infusion port and the second port for instrumentation. So 2 conjunctival peritomies were done in the area that were absolutely devoid of any kind of scarring due to previously done surgeries. A refractive marker was taken and 2 holes were made exactly opposite to each other at a distance of 1.5 mm from the limbus. Now, partial thickness scleral pockets were made alongside the 2 holes with the help of a crescent blade. Since the eye was already vitrectomized, periphery was checked for any evident breaks. Now the tip of the haptic was held with the help of a max grip forceps and that tip was taken out through the hole that was previously created. Now, to prevent a slippage of haptic inside, a silicone plug was inserted. The lens looked entangled on one side, hence a forceps was used to bring the lens in the center. But the lens haptic seemed to be stuck somewhere, either in the sulcus or in the ciliary region. Hence, an IOL tap method was used. So, if you see very closely with the help of the max grip forceps, the optic of the IOL was gently tapped, as a result of which the haptic that was stuck fell out in the anterior vitreous cavity. Once this haptic was absolutely well visible, the max grip forceps was used from the other hole that was made and the other end of the haptic was taken out. Since both the haptic ends were out, they were gently or snugly tucked inside the scleral tunnels or the scleral pockets that were previously made. Oh gosh, the IOL looked absolutely stable and it was God's indication that yes, he had made it possible. To finish off the case, the conjunctiva that was opened was beautifully sutured, making sure the haptic is not visible at the end of the surgery. Once the conjunctiva was sutured at both the ends, both the ports were removed. The IOL looked absolutely central and stable. 1 month post-op, the patient came in with an improved visual acuity, with well-buried haptics and an absolutely stable intraocular scleral fixated IOL. The cornea, luckily, did not undergo any major decompensation. The retina was well attached, and in spite of having a mild foveal thinning, the patient was absolutely happy and delighted. Despite undergoing so many surgical procedures, her radiant smile shone brilliantly, transforming our collective efforts into a truly rewarding and a heartwarming experience. Thank you very much for patiently listening.
Thank you very much, David.
Thank you, sir. Thank you.
Dr. Rajesh,
Yeah.
he succumbed or rose to the situation?
Well, he handled it very well because these cases are difficult scenarios, and he showed that there was so much of damage in the area where the IOL could be fixed. A couple of things that I would like to differ here is that one, I felt the orientation of the IOL was inverse. That was one.
Yes. So,
Yeah, and the second thing is that in these cases, we do get good visual outcome inside your clinic. But once the patient moves out, he has a lot of photophobia.
Yes, yes.
So in such cases, I would rather prefer to use an aneridic IOL,
yes.
and that gives a better
Absolutely.
result. The patient is more comfortable,
Absolutely.
particularly in outdoors.
Yeah, so I agree to that point, sir. Absolutely agree. The only problem is the optic of the aniridic SFIOL is 10 mm.
9
So
mm, yes.
So to open an area, there is no area to open now. So that was the only reason I refixed that IOL. And luckily for me and the patient, she was one-eyed, so I could give her photophobic glasses post-op, and then she was like doing well.
Maybe post-op, I mean, not about the surgery, but maybe there's another option that you can do is that you can give a pupil optic contact lens in these cases.
Yeah, absolutely.
So then what will happen that the central pupil 3 millimeter is clear, that is clear pupil, clear optic, and then the peripheral part is tinted. So that will be useful in these cases.
Thank you, thank you.
Dr.
Point
Saurabh?
very well taken, sir.
Something to add before we, yes.
I think nothing more to add. I think he did perfectly well in the circumstances, and as he said, it was the least invasive of all the
Yes.
IOLs
And this was
that
the third procedure in the same eye
yes,
in the in 1 month. So
Yes. Yes, Mohan sir?
yes, yeah.
I think, Devat, really congratulations to you
Thank
for
you.
a
Thank you,
wonderful,
sir.
very difficult situation because the sclera is all butchered up and the conjunctiva is all round, and you did it so well. Only thing is when you lose a haptic there, that haptic, see if you try to tuck the optic, no, what will happen is you do not know whether it's pulling somewhere in the peripheral retina. That's a problem. So what I do normally when you do the glued IOLs, when you have dislocated IOLs coming up, is you do what is called the handshake technique. You take 2 microforceps and go along the haptic and catch and re-grasp. Grasp and re-grasp so that you go to the tip of the haptic. The tip of the haptic has to be taken out. So in this way, you don't have any traction. You do not know what's happening underneath. That's a problem.
True.
Unless otherwise you...
Absolutely.
In
that
one
area,
thing which I want to differ, but I think overall, fantastic.
Thank you so much, sir.
Thank you, sir.
Thank you, Devat.
Thank you, sir.
Let's move on to the next presenter, and that is Dr. Nivedita Das. She'll be presenting her case of descemet membrane detachment. Nivedita? Okay. Yeah, can you play the video, please?
Descemet membrane or DM detachment can be a potentially vision-threatening complication of phacoemulsification surgery. Visually significant central detachment is easily managed with air tamponade if recognized early. However, late presentation, especially with taut and scroll margin, is a challenging task, demanding specialized techniques of descemetectomy to cut open the adhesion and releasing tension, along with gas tamponade by perfluoropropane or hexafluoride. This video will demonstrate intraoperative difficulty and successful management of one such case of old stiff DM detachment. A 48-year-old woman presented with persistent corneal edema after 2.5 months of phacoemulsification as a result of repeated failed attempt to form the anterior chamber by the primary surgeon. On examination, there is central corneal edema, DM folds with peripheral scroll and scarring. Anterior segment OCT revealed a large, non-planar central DM detachment with peripheral tightly folded border of DM. Descemetopexy with tamponade by isoexpansyl perfluoropropane or C3F8 injection was planned to manage the condition. After peribulbar anesthesia, epithelium was debrided for better visualization of the anterior chamber. Prophylactic inferior surgical peripheral iridectomy was made to prevent papillary block post-injection. Gas injection was started through a side port in superior clear area. At first, a small bubble of C3F8 was given, followed by a larger one, but the bubble was irregular due to multiple points of unfolded descemet margin. In order to spread the rolled up wrinkled DM margin, I tried to insert a dialer under the bubble to break descemet tension, but the anterior chamber was suddenly collapsed, preventing further maneuver. Then subsequent gas injections was also failed and gas entered behind the iris to complicate it further by making the AC progressively shallow. At this moment another side port was made at 2 o'clock position. Saline was injected to remove the trapped gas underlying the iris by burping it and aspirating the bubble. Conventionally, cutting by 30 gauge reverse cystitome bent tip needle is used to release the taut impacted DM. But in this case, the tip of the 27 hydro cannula was used to stretch and enfold the rolled stiff DM from center to periphery by breaking the adhesion. Air then injected through the side port, a little bigger bubble formed but a kink at the bubble is still visible unferonasally due to detached DM with adhesion. A ball tip of a dialing instrument is again introduced from left side port to unscroll and centripetally stretch the stiff DM in the unferonasal area with a swipe movement. Gas was injected and now a satisfactory full chamber bubble was formed. Venting incision done near the phaco wound to remove possible trapped fluid inside the detachment. Side ports are sutured and surgery was completed. But after 1 month, a nasal detachment recurred which is successfully managed with repeat air tamponade through superior side port. Finally, after another 1 month, patient had best corrected distant visual acuity of 20/60 with clear cornea and specular CD count 2767 cells per milliliter square and 484 micron central corneal thickness. So, it's truly said, when the going gets tough, tough gets going. We can always try even in a late decemate detachment to undergo decimetopexy before straightforward endothelial transplant. Thank you.
Thank you, Nivedita. Judges?
I think it's a very educative case. First of all, showing us that it's not a good idea to wait a long time before repairing destimate detachment, because it's become fibrosed and it's much harder to repair that case. And second, my second comment comes to you try to unscroll this decimate. So I would probably rather, after unsuccessful attempts of unscrolling, I will think about decimatotomy rather than trying to unscroll it, because it's a scarring tissue, thickened, fibrosed. So I see no issues in cutting this area out, either completely or just doing partial cut, and then going on with the gas as you mentioned. And my third comment is that in DMEC and DSEC cases with not very good capsular and IOL support, I like to do venting incisions. But if the anterior segment is intact and the lens is perfectly in the bag, so I think if endothelium is working well, so there is no reason to do the venting incisions, because endothelial will anyway suck the edema out of the cornea. So, but anyway, so you did it great, and the result was perfect. So there are many ways to do the same things. So that probably will be my approach, which is probably not better than yours, because you did it well.
Thank you so much, Dr. Rajesh. Yes.
Yeah, actually it was very well managed, and I think most of the things that is needed, you have done it. And most of these taut membranes we have done a study with Dr. Dua also, we have published in AJO. So most of these taut membranes are detached Dua's layer along with desmase, because if it's only desmase, it will be undulating kind of. So these taut membranes only then later have a tendency to become more tough and a little bit of fibrosis, because as such desmase does not cause fibrosis. So in such cases, I will completely agree with what Dr. Boris told, that maybe one desmatotomy helps in such cases. You do a desmatotomy and then inject air, it may cause little bit of spread of that tear, but then the rest part will completely attach. And that works very well.
Thank you so much, Dr. Nivedita. So next we have Dr. Karan Bhatia, who will be presenting his case of Everest of corneal surgery. Karan, come on the podium. Yeah. Can you have his video, please? Yes.
Everest of corneal surgeries. 6 complex procedures at once. So an 18-year-old boy with an inherent glaucoma in the only seeing eye came to us. An RK marker was used for intended suture locations, followed by the host cornea definition. This was done using a manual 9 mm corneal trephine, followed by a vertical entry was made with the side port knife, and a host corneal button was cut 360 degree using the corneal scissors. The next step was the donor cornea definition. This was done using a 9.5 mm manual trephine. There were multiple iridocorneal adhesions. It is extremely important to break them. After this, the entire host cornea button was excised. As you can see, there is a decentered IOL with a fibrous capsular bag. If you look carefully, there is a central opening there. This could either be a posterior capsulotomy or a posterior capsular end. The anterior capsular fibrosis was trimmed and cut and removed. There was some vitreous prolapse which was manually cut. A fibrotic rim was also cut using the same scissors. An attempt was made to center this pre-existing IOL. However, it was very difficult. So I decided to do an IOL explantation. Using a Sinskey hook, this IOL was rotated and nudged out of place. To my surprise, one of its haptics was broken. The next step was open sky vitrectomy as there was vitreous prolapse. The next step was synecholysis. It is very important to break these iridocapsular adhesions because this is where we want to put our IOL, followed by breaking the peripheral and anterior synechia. The next step was the IOL implantation. This was done using a 3-piece PMMA IOL into the sulcus. You can see a well-centered and stable IOL. This was followed by pupilloplasty with 10O proline sutures. One has to be very gentle and careful over here because this iris is very friable and weak. Any rough manipulations can damage it. Pupilloplasty in such case was done at multiple locations. You can see a very good pupil. The next step was to complete the keratoplasty. The donor cornea button was placed and was sutured to the host trim with 10O nylon sutures. The AC was formed with air. An intraoperative astigmatism was managed using a Maloney's keratoscope. Post-operatively, the patient was extremely happy and saw colors for the first time in his life. So penetrating keratoplasty, IOL explantation, synecholysis, vitrectomy, IOL implantation and pupilloplasty, making it 6 complex procedures, the Everest of corneal surgeries.
Thank you so much, Karan, for showing this wonderful case. Judges, Dr. Rajesh, Dr. Kumar, yes. Mike, please, yeah.
So very well presented. You said that the original lens was, the haptic was broken when it came out. So was it implanted by the original surgeon as a broken lens, or was it that you broke it while bringing it out?
So don't know about that. Could be the haptic could have been retained inside. That is the most probable scenario.
What was the post-op vision and how was the retina?
So retina was fine, and the vision was I think I don't remember, but 660 approximately. The patient was doing well.
Very good, very nice.
Karan, it was very well managed, and many a times in these cases when you are doing a keratoplasty, there's a tendency for the globe to collapse. So use of these Fleringa ring is very useful because whenever you do a little bit of vitrectomy in such cases, globe starts getting collapsing. So Fleringa ring helps.
Absolutely. Sir.
Yes, sir.
Why didn't you use an automated vitrector? Now, why you use a sponge, Devaker scissors or whatever it is?
So it's not going to do that job. So only with automated vitrectomy we will be able to achieve a good vitreous cut and removal. With the scissors it won't be that effective.
No, you use the scissors, no?
So in the start the vitrectomy machine was not ready by that time.
Okay.
So that was the only reason I had cut by that time.
Okay, that's right. Otherwise, well done.
Thank you, sir.
I think overall excellent job was done, but more we keep the eye open for a longer time. Chances of expulsive choroidal hemorrhage. I had one such this, but here even after a long gap there was nothing happened. But we have to be prepared to do it faster. But overall, excellent job done.
Gave
Thank you, sir.
preoperative, intraoperative mannitol also.
Yes, sir, definitely. So I always have an IV line also open in
Yeah.
just in case, and I don't discard that button until I've sutured the thing. So if something happens, I can put it immediately.
As Rajesh was telling, flaring the ring is probably
Definitely.
would have been very useful because
Definitely.
avoid, especially when you are doing a vitrectomy, removing the IOL, lot of hypotonia would have been there.
Definitely, definitely.
And you was doing it, this case under general or
Local.
local? Okay, so I would rather consider if the general condition of the patient sometimes does not allow you to do that. However, I will be more comfortable to do these cases under general to decrease the chances of unwanted effect already mentioned. Yeah.
Thank you so much, Karan, for showing this case. And next we have
Thank you, sir.
Dr. Bharti Megur will be showing her case. Dr. Bharti. Can we play her video, please, with the audio?
A seemingly routine phacoemulsification procedure, but why is the pupil being irregular here? Hi, let me share an interesting and uncommon experience which I recently encountered. He is a 65-year-old gentleman who is posted for cataract surgery. Rexis has turned out slightly smaller than what I would have preferred. Hydrodissection is being done. As I am tapping down on the nucleus to decompress the bag, the capsular bag seems to be moving along with the nucleus. This suggests zonular weakness. I confirm the nucleus is free from its attachment with the capsular bag by rotating the nucleus. Time to emulsify the nucleus. The nucleus is moderately dense. Vertical chop is being performed. The posterior plate is not cracked during the initial chop. The nucleus is rotated and the nuclear division is continued. As the nucleus division process is being continued, I realize that the iris is trying to come out through the side port. A little bit of OVD puts it back in place. The nucleus management is resumed. A few moments later, I notice the same iris coming out through the side port. But this time, I noticed something else. The capsular bag is decentered away towards my right. Well, this wasn't a good sign. It was suggestive of transzonular vitreous prolapse from that quadrant. Diluted triamcinolone demonstrates the fibers. At this juncture, my primary goal is to deal with the prolapsed vitreous and temporarily withhold nucleus management. The vitrector is introduced into the eye and the prolapsed vitreous is taken care of. These are the settings used for anterior vitrectomy. Once I was certain that the anterior chamber is clear of the vitreous, it is time to stabilize the bag. OVD is injected, a CTR is then inserted. The insertion process is smooth, with the bag now being well stabilized with the CTR. Using two Sinskey hooks, the posterior plate is separated with good control. Under the cover of OVD, the nucleus emulsification procedure is continued. Before beginning cortex aspiration, diluted triamcinolone acetate is used to confirm the absence of prolapsed vitreous. Cortex aspiration is done carefully. The cortex in the area of zonular dehiscence is sticky and difficult to aspirate. I decide to deal with it later. Bag is inflated with the OVD. Multi-piece IOL is placed into the bag. Care is taken to ensure that one of the haptic supports the area of zonular dehiscence. The cortex near the area of dehiscence is eventually aspirated. The OVD is removed. The lens is very well centered. These are the post-op pictures. The patient is doing fine. To summarize, the lesson I learnt was never to take anything for granted. Seemingly innocuous cases can surprise us, especially with pseudoexfoliation. There was no obvious sign of zonular weakness at the slit lamp examination, which was worthy of raising a concern. But still, even a mildly stressful maneuver can worsen the pre-existing zonular weakness. Iris trying to peek into a leaky side port can be seen in our routine cases as well. One needs to be mindful and also observe the position of the capsular bag. In the event of a suspicion of decentering capsular bag, it would be wise to rule out transannular vitreous prolapse. If transannular vitreous prolapse is confirmed, the other steps need to be stopped until the vitreous is taken care of. Timely CTR insertion stabilizes the bag and makes subsequent nucleus management safe. Thank you.
Thank you very much, Dr. Bharti. Dr. Arup?
Excellent demonstration. That's the best way to do this situation. But yes, you can put iris hook, rather implant CTR in the at early stage. Some surgeon prefer to put capsular hook here. But otherwise, it's excellent demonstration.
Thank you very much, Dr. Bharti, for your case. So next we have Dr. Purinder Bhasin, who will be showing his case, All is Well That Ends Well. This case is about subluxated cataract. Can you have the audio, please, Dr. Purinder?
This was a grossly subluxated lens. As you can see, with a large area of bare vitreous, we managed to do the capsular access and fixated the lens bag with the capsular hooks, and almost more than 180 degree of subluxation was there. So we managed it and did slow motion phacoemulsification, as we do it in routinely in all such cases, and plan to implant the Sioni ring, which a suture 9O proline suture is passed in the haptic, and a bent needle is then passed out through the sclera, and it is fixed in the scleral tunnel. And up till now everything is going fine, and because some cortex is also there, but suddenly you see that because of the overpull, we created zonular dialysis on the opposite side, and we have now the situation where there is a 180 degree is already zonular dialysis was there, and this was created by us, but we have a bag with the Sioni ring inside, and then after removing this cortex, we saw that there is a PC rent. So we waited for some time, and then we brought proline suture with 2 straight needles, and then guided by the hollow needle, the straight needles are proline suture is passed through the sclera, the Sioni ring, and 3-piece lens is now fixated in the sulcus, and the optic capture is done into the intact capsular axis. And this way, at 1 month, patient's vision is good, and at 6 months also, the patient stabilized. This way, we could fixate the IOL, because there was no place where if we would have placed the lens in the sulcus, it would have slipped back behind in the vitreous cavity. If we would have placed the lens in the capsular bag, because of the PC rent, it would have gone inside. So this way, we engage the lens, and the patient is doing well. Thank you.
Thank you very much. Nareen, Dr. Nareen, your quick comments before we move ahead.
I think absolutely wonderful show of skills, sir. I think there's nothing else to add. I think everything was done perfectly. I could say, I think only thing is, sir, do you know at what point the PCR happened?
I think it happened during that slipping only, and which we could see only after removing the remaining cortex, which was there, which we could see during that time only. Maybe during removal of the last piece, because there is a floppy posterior capsule in such cases, it must have touched the phaco tip.
But fantastic. I think after you anchor the bag, doing an optic capture, I think it's a wonderful idea, sir.
Thank you so much, Dr. Purinder, for this lovely video. So next we have Dr. Swati Agrawal. Will be showing her case, Mayday Calling.
Mayday, Mayday, emergency, emergency. Mayday, Mayday.
Not every a smooth sail. Well, some days are May days. This was a hypermetrope female with a shallow AC, PI done. Pupillary dilatation was paracentral, but I achieved a central rhexis. Hydro was done, but the lens saluted. And I had a premonition of something not going well, so I decided to prolapse the nucleus into AC for enhanced safety. And my premonition came true. There was so much of an upthrust so as to not allow the phaco probe from entering. I tried using a second instrument to release the iris tissue from the phaco probe, but it started bleeding. The turbulence couldn't be controlled for a while. Phacoemulsification was started. But now the nucleus decided to go back into the bag, and I decided to trench. I tried repositing the iris from the side port wound and gave block of viscoat over the iris, but the iris kept prolapsing. Tried displacing a little bit of viscoelastics by tapping at the main wound, but this led to an iatrogenic iododialysis. And I decided to go in with iris hooks and then proceed with phacoemulsification. Bimanual IA cortical wash was done. And IL implanted. The iris hooks were removed and the iris was ironed with spatula to assess the degree of iododialysis, which was temporal and 1 to 2 clock hours. So gave in pilocarpine and then viscoelastics. And changing gears, now I'm sitting superior, made a temporal scleral groove 1.5 millimeter from the limbus, inserting a tenoproline needle from the temporal groove and docked it into a 26 gauge needle from the opposite side port. The tenoproline was taken out from the opposite side and reinserted it, taking care with the help of a spatula so that there are no bites in the corneal or iris fragments. Now going from above the iris this time and docking into a 26 gauge needle, it was taken out from the scleral groove. But this was a mayday. The tenoproline had bitten into the corneal fibers in spite of all the precautions. Tried releasing it with the help of a side port blade. This procedure went on for a while, and then with a spatula, but to no avail. Ultimately, after all the turbulence, the Vinas did the trick. The tenoproline was tied in the scleral groove 1.5 millimeter from the limbus at its normal anatomical position. The knot was tied a little loose so as to allow the iris to hang back a little. The wounds were closed and a mid-sized air bubble given. This was the post-operative picture of the patient. To sum it up, in spite of all the turbulences, the landing was done successfully. Thank you.
Thank you so much, Dr. Swati. Dr. Gaurav, your comments, please.
Very well managed, Dr. Swati, because in fact, see, the moment you put in the iris hooks, everything fell in place. You started having, it became almost like all the turbulence was gone. So I think what matters is that when you are having a floppy kind of an iris and you have a challenging cataract, maybe like a small pupil, a brown cataract, and you already know that you're going to end up, it's only going to get worse with time. So at the right time because then the iris will start coming in. So if you're towards the end of the surgery, for example, you've already chopped all the pieces and you're coming towards the end, when the pupil starts coming down, it's okay to proceed. But when you are right at the beginning and your visualization is not great, it's good to kind of, put those supports on the pupil before it becomes much worse. And the iris, because you're using high settings for chopping, it's a hard cataract, the iris will tend to come, towards the phacoprobe, but you manage it so well. And then also the iridodialysis repair, I think you did a good job. The only thing I might want to add here is that when your iris was coming out, one thing is don't overfill with visco, because moment you try to put in more visco, the iris will come out. And second thing is you did the right thing by using viscode. Also, when you want to pull the iris back in, it's a good idea to go from the side port with a small instrument. It does two things. One is from the side port, it allows some visco to escape. So it kind of makes the chamber less taut. Otherwise the visco will come out from the main port with the iris. And then from the side port, you go to the main port and gently kind of tug on the iris, then you won't create a dialysis as often. Otherwise, putting it from the same port, if you're trying to kind of do it, it'll tend to produce that. But you managed it so well and very nicely done.
Thank you, sir.
I just want to add one point, because what is the reason for the sudden upthrust? Was it because of too much of fluid which has gone behind into the zonules and
So it was from the very start. This was a hypermetropic female with a shallow AC, had done a PI earlier, but there was a lens salute. So basically there was probably that
I
precipitated
think it was a very
iris.
aggressive hydrodissection, I thought. Yeah, and a little larger excess,
Yeah,
but whatever it is. But what I would have done, I put a trocar and cannula into the pars plana in such situations when you have it's something like an acute intraoperative rock artery syndrome, ARIS. So something like that, when you have an hyperopic eye, just put a trocar and cannula, and what happens is you just do a vitrectomy at the end of this thing, a dry vitrectomy, that will actually decompass the chamber. And also, as Gaurav said, don't try to, when your iris prolapse is there, don't try to push it from the main port. Always go through the side port. Main port, then a lot of holes in the iris will come, iridodialysis.
Thank you so much, sir, for your comments. Thank you, Swati.
Thank you.
So next we have Dr. Sugata Paul, will be showing very interesting case of posterior capsule rupture.
Yeah,
Dr. Sugata Paul.
Thank you, Harshul, for giving me the opportunity. Everyone has shown challenging cases where they have planned the challenge to take. Here I have created a challenge for myself while implanting a VVT IOL, the second eye. Hydroimplantation, as you know, has several advantages, like no visco removal is required, better rotational stability, no spike of IOP, no TARS, but it can give rise to shooting out of IOL, as it happened in my case, and unfortunately it ruptured the posterior capsule. Now what to do? My first reaction was to take it out, but then I realized this is the second eye. The first eye has VVT. What to do? So I thought of holding the IOL, but then I supported the IOL with the irrigation cannula and tried to curse myself and tried to think why I have done this, but at the same time assess the situation. Then I saw vitreous was not there. I created a compartment with injecting visco behind the lens, and I realized that's the ruptured area. So little bit of capsule is there, whether I can salvage or not. My leading haptic was in the bag, but my trailing haptic was in the sulcus. So my job was to put the trailing haptic in the bag and see if it is stable. So that's what I tried. After forming the anterior chamber, pushing the IOL back, gently I nudged the haptic optic junction under the bag and just push the haptic inside the bag. So what lies behind is only small remnant of the capsule. So I thought it might not be a stable situation. So I tried doing optic capture, and luckily I failed, because what it would have happened, it would have given some refractive error. So I tried here doing reverse capture, but it failed. So I keep it in the bag, left it like that, and this is an edited video. I waited, I nudged the lens, see it was stable. I washed the vitreous away. And I was thinking why it happened to me and what I can do so that it doesn't happen to me in future. How I can utilize hydroimplantation, but how not to have a shooting out of the IOL. Only option in this situation is using screw injector. But in screw injector, what happens? You have both the eyes, hands engaged. So here in this case, what I am showing is the IOL was stable, no vitreous. So I decided to put pilocarpine, hydrated the wound, and the pupil was round. And I left it like that. The patient came back on the second day, and this is on table, sorry. And second day, the eye well was absolutely in position, and this is the video on the second day. Eye well in position, you can see the ruptured area. So what I'm doing now in this situation, I'm taking the help of the God. So as I've said, screw injector is much more controlled delivery, but both hands are required. So I'm taking the hand of God, sorry, not God, hand of my assistant to screw the eye well inside. So here you can see my assistant is screwing the eye well where I'm holding the injecting A, and I'm getting the benefit of both worlds. Screw injector, control injection, hydro implantation, no visco removal, no better rotational stability, no IOP spike, and no TAS. Thank you so much.
Thank you so much, Dr. Sugato Paul. Dr. Kumar?
I think what you have shown is very, very good, that there is no doubt that the screw injector does help because you have a control. Sometimes if you are not in the right plane, you can further push it down. So there is no doubt that this works very, very well. But was it your push of the injector which caused the PC to rupture,
Yes.
or did the hydro stop at that moment?
No,
because your mind went to the injector and you stopped the irrigation.
No, there were two things actually, if you
Yes.
notice. I didn't stop the injector, it was in continuous flow, but whoever is doing hydro implantation have to make sure there is no wound leak. There, if you go back to the video, there was wound leak from the side because that patient had slightly, I think 0.6 astigmatism, so I made the wound slightly enlarged. So in this situation, there was leakage of fluid, and that's why the capsule came up. But lucky to me, because the capsule came up, the lens hit the capsule, it didn't hit the vitreous because the capsule was away. If that situation happens, either you should go back and use visco and use the implant, or you just tilt the injector slightly so both the lips are sealed and you are not getting the leakage.
So one important take-home message would be that you should be in continuous irrigation when you're doing a hydro implantation.
Yes.
Thank you so much,
Thank
Dr.
you.
Sugato.
Thank you.
And wound assisted delivery. You're not allowed to.
Yes, but still with pusher does shoot out. It has happened to me before, and now with the screw injector is gone.
Thank you so much, Dr.
Thank you.
Sugato. Next, I'll invite Dr. Sudipta Mitra to please come on the podium. All is not always lost. Can I have the video of Dr. Sudipta? Yes. Okay. Can we pause it for a second? Yes. She has to narrate the video. Okay.
For including
Welcome.
me in this. All is not always lost. This was a hypermature cataract of a pseudophakic other eye patient, a young diabetic patient, and was planned for a toric IOL, which is a good cylinder power. So I stained the capsule as a routine procedure, went on with cystitome, and there was a fluid leak. I was ready, so immediately I thought of sucking it out with an empty cannula fixed with an empty syringe, and then proceeding. Usually I don't keep this capsulexis marks, but here I thought I would. So I proceeded slowly. I was keeping my calm, but I saw a lot of fluffy cortex. So I thought I should make a smaller axis compared to what I usually do, 5 or 5.25. And in between, I was also trying to suck away as much as possible, because although I had tried decompression of the bag, I was a bit apprehensive. The patient was young, the other eye was pseudophakic toric, this was toric, so naturally I was a bit apprehensive. And in this process of my enlarging the rhexis, doing the rhexis, I did a smaller rhexis, but it was not going as I wanted. So again, with controlled fluidics or controlled viscoelastics, and I went on sucking a bit of more of the fluffy cortex as much as possible, keeping the rhexis margin flat. At this point, I thought I should go for a rhexis forceps rather than go for a cystitome. So I went to the main wound and I used a rhexis forceps, picking it up, rubbing it again, and it looked okay, but this was a very stormy day for me. So there was a run out as I was apprehending, So I just cut off that margin, and this was my rexus, which was irregular, and I had to think what to do next. I did a little bit of visco hydrodissection, very little, and I thought, let me try phaco. With controlled fluidics, low fluidics, I went slowly. I did a direct chow and tried to look at the flap. The flap was turned upwards, which said that it might not have gone to the equator. Under direct visualization, good dispersive viscoelastics, low fluidics, controlled phaco, and protecting the flap with a spatula, I could complete my phaco and without much event. And I did not allow the anterior chamber to collapse at any point. So this was my rexus, and again with controlled fluidics, I could complete my irrigation aspiration. Now for the IOL, I was thinking what to do. A toric IOL in this situation would not be good, but I said let's try it out. Until we face the storm, we do not know what's going to happen. So, but I did a visco delivery, not under irrigation, because I thought I may not be able to keep the pressure stable, and I tucked the haptics rather than dialing them. I waited for some time and did a bit of irrigation. I found the lens was quite stable, so I did not disturb the procedure, put a bit of pilocarpine, and then under hydro, I tried to look at the position of the markings and found that it was absolutely well placed. Thank you so much.
Thank you so much, Sudipta.
Until we face the storm, we do not know how it is going to end. Thank you so much.
Thank you, thank you. Jagatram sir, quick comments from you. Then I'll invite Dr. Manik Sardana to please.
I think you have done excellent job, and because whatever you could save the adequate capsular support and implant IOL into bag. Ultimately, that is what is required.
Thank you so much. So we have last two presenters, and then we have the awards also. Dr. Manik, please come. So he'll be showing a case of phaco and hydrodialysis repair. Can you have the video of Dr. Manik, please? Yes.
So this young patient had blunt trauma and presented with iridodialysis, which was in two quadrants, inferiorly and temporally. So I planned a combined surgery for cataract extraction and a two-side iridodialysis repair. Firstly, conjunctival peritomy is done in the area of iridodialysis repair. Note the inferior and temporal iridodialysis. Then two partial thickness scleral flaps are raised corresponding to the areas of iridodialysis. Another flap is raised in the area of iridodialysis. So this was one of my initial cases as a senior resident. So then a side port is made opposite to the area of iridodialysis. Another side port is made for iris hook. Then anterior capsule is stained with trypan blue dye. Iris hooks are applied at 6 and 9 o'clock position in the area of iridodialysis. 2.2 main port incision is made. Then CCC is done with the help of capsular access forceps. Then multi-quadrant hydrodissection is done. Free movement of nucleus is noted, and then routine phacoemulsification. This was a softer nucleus. The patient was 35 years old only. So yeah, the phaco part was easy. It was a soft nucleus. It was gently emulsified. Then the iris hooks were removed, and the iridodialysis part will be taken care. A multi-piece IOL was put in the bag. Nino polypropylene suture, the straight end is entered into the anterior chamber under the scleral flap 1.5 mm from the limbus. It is engaged into the iris and threaded into the lumen of a 26 gauge needle. Then adjacent to this previous site, a 26 gauge needle is entered into the anterior chamber and iris tissue is engaged. Then the same end of nino polypropylene is brought out from the adjacent site. Then the two sutures are gently tied and multiple knots are tied to fix the iris. Same steps are repeated in the inferior quadrant. Firstly, 9-polypropylene is entered, then it is engaged in the iris tissue, it is brought out. Note that the counter traction is applied with the help of a max grip forceps so that we do not pull the iris. That is brought out and knots are tied. Viscoelastic is removed at the end and the peritomy is closed. This was day 1 and this was 3 weeks post-operative. Thank you.
Thank you so much, Dr. Gaurav and Dr. Rajesh. Can you please give some comments?
Well, it was well managed, I must say that. Only thing is, sometimes when you have a large dialysis, it's better to distribute the force of the suture. Maybe, instead of putting one, you can divide it into two so that there's no notching. That is one thing that sometimes I have felt. Otherwise, it was very well managed and nicely done.
Thank you, sir. So, there were 2 iridodialysis in the office.
Yeah.
Thank you.
So again, nicely done, and I appreciate the fact that you first supported both the areas of dialysis with a hook. Otherwise, sometimes those are the areas where the iris will come in and create problems for you because it can get into the phaco handpiece. But the other thing to further refine your surgery would have been to use a Hoffman's pocket instead of the scleral flaps. It's much more elegant. This doesn't disturb the conjunctiva, and the knots get buried very nicely. So you could have easily done 2 Hoffman pockets, one in each place, and you nicely supported the iris when passing your suture. That's another take-home point. If you don't do it, you will tend to increase the dialysis, and sometimes you can actually use a railroading technique also. Rather than support it with another instrument, you can take a 26 gauge very close to where you want to pass the suture and engage the suture needle into the 26 gauge, like railroad it and bring it out. That gives support as well as gives you the precise placement of your suture onto the on the cut edge of the iris or the loose end of the iris, the root of the iris. But otherwise, very nicely done.
Okay, sir. Thank you.
Thank you so much, Dr. Manik. And we have the last but not the least, Dr. Aanchal Thakur, who will be presenting her case of fibrotic anterior capsule. Please come here. Yeah, you can be there, no problem.
Yeah.
Can I have the video?
So this was a 29-year-old male patient and he had a acute status post hydrops. He had a big corneal scar, and along with that corneal scar there was a large fibrotic anterior capsule. So we often deal with these situations. There is wrinkling, there is fibrosis, but this capsular fibrosis was quite large. So after making the side port and staining with the Japan blue dye, I started doing my rexes with a cystitome. Usually we can get away with this if we can get a softer area for a anterior capsule, but with multiple attempts I was not able to get a nick on the anterior capsule. So there was difficulty in performing the can-ocular capsulotomy, and it failed again and again. I tried to inject, flatten the anterior capsule with viscoelastic, and again tried with the 26 gauge needle. But then I realized that at the periphery where the capsule was relatively less thicker, I tried to inflate, and at quite periphery, I think it was around 6.5 millimeter, I could achieve a nick, and it was a white fluffy fluid which came out. I aspirated and then I started using a cutter. Now the important part is what should be done now. Should we go ahead with the cutter capsulotomy, or we should use the vanas or a micro scissors and cut the fibrotic capsule at the periphery. I tried going with the cutter capsulotomy with a cut rate of 400 and a maximum of 500, and tried to cut the whole edge of the beyond the fibrotic capsule with the cutter. Care has to be taken to inflate the bag because it was soft cataract and the posterior capsule was also trying to come and touch the anterior capsule. So repeated cohesive injections to push the posterior capsule back, and patiently the anterior capsule was cut using the vitrectomy cutter. aim of a cataract surgeon is to achieve a small, centered, good rexis, but this couldn't be achieved in this case. And finally, the whole fibrotic capsule was removed with the cutter. The capsular bag was then filled with a cohesive viscoelastic, and a 3-piece intraocular lens was injected. There are many techniques to do this. People use Zepto rexis or flow capsular rexis also for doing such cases, but I chose a vitrectomy cutter to do the rexis.
Thank you so much, Dr. Anchal, for showing this. Here's Dr. Rajesh, your comments.
I was just wondering, you did a lot of hard work, yeah, and it was a difficult scenario, definitely. But then it had a very large corneal opacity, and later on the patient will require a keratoplasty.
So this was a second
And
stage.
that will result in, the refractive error that will be induced by that. So,
Actually, the patient presented with a counting finger vision. It was a patient of Down syndrome with hydrops, post-hydrop scar and white cataract. So I planned, like first I'll do the cataract surgery and then we'll go ahead with the keratoplasty later.
yeah, so maybe keratoplasty first and cataract. Along with that, maybe it will give somehow a better result.
Very well presented. Only thing, this is damn tough to cut with a cutter. Micro scissors would have helped you much easily, and you would have gone all around much easier. Because cutter, sometimes you are lucky you could finish it. Sometimes we fail with a cutter also. I think it was a brand new cutter. Otherwise, I don't think you would have succeeded. It was quite a tough one. Well done.
Thank you so much, Dr. Anchal. And thank you so much, all our esteemed judges and all the presenters for their wonderful presentations. Now we have some awards to be given for this session. And as I said, we have some consolation prizes for all those who submitted their beautiful videos. Dr. Saloni Sinha, she's here. Yes, please come. Dr. Jayashri Barua, please come on the stage. I'll request our Chief Judge, Dr. Boris, and other judges to please give away. Dr. Ashish Lal, is he here? Dr. Neetu Latif, and Dr. Meera Rahim. So these are 5 consolation prizes, and they get the pen drive. Please come, please come. Come. Congratulations. Dr. Jayashri. Yes. Your videos were very good, all of your videos, yeah. Please come, collect. Yes. So now we have the runner-up, toughest girl and toughest boy award. So runner-up, toughest boy award goes to Dr. Karan Bhatia. Yeah. So he receives a trophy and a hard disk of 1 terabyte. A lot of storage, huh? And I'd like to thank Microvision team, Mr. Ashok and this. Very nice. And the toughest girl runner-up goes to Dr. Nibedita Das. Thanks to Microvision team for arranging all the uniforms for us and for contributing to the academic grant. Thank you so much. Dr. Nibedita Das. Now we have the award for the toughest girl winner, and that is Dr. Vanashi Nair from Cochin. And the toughest guy for 35th season, none other than Dr. Nilesh Kumar. I'll request all the presenters to please come on stage. We'll have a quick photograph and then we'll hand over to Ramamurthy sir. Maipal sir, yeah. Congratulations, congratulations. एक फोटो ले लें. And these pen drives are for all the presenters. They'll collect after the photograph, yes.
Come, you want to start first? Yeah. Aa jao, start. Can I request all the co-instructors for this present course to come up?